Dr. Nirav Shah is the Senior Vice President and Chief Operating Officer for Clinical Operations for Kaiser Permanente, Southern California region. He is a thought leader in patient safety and quality, the social determinants of health, and the strategies required to transition to lower-cost, patient-centered healthcare. He is board-certified in internal medicine and is a graduate of Harvard College and the Yale School of Medicine.
So with our introductions out of the way, we're going to turn things over to Dr. Shah, who is also with us virtually. Dr. Shah?
Good morning, everyone. Thank you so much for hosting me virtually. And Secretary Walker, I appreciate the invitation. Before my current role, I served as New York State Health Commissioner, and so I have some of the ideas of some of the challenges you must be facing as providers in 2017. So I thought I'd start by telling you a story and then leave time for a lot of questions as well. Last year, Jess Jacobs, the head of innovation at Aetna, blogged about her care experience with two rare diseases. Jess is trained as a Green Belt Six Sigma, so she would write about a 12-hour wait in the emergency room as having 7% process cycle efficiency. Over the course of a year, she documented 56 outpatient doctor visits, of which 29% were useful, 20 visits to the ER, and 54 days as an inpatient across 9 hospital admissions. Her calculations showed that only 0.08% of that time was spent treating her condition. For her, time saved equates to quality. Speed is quality. And in healthcare, we deliver very little quality when defined by a metric that matters to our patients, their own time. How did we get here? Well, I like to say that in the United States, we have a perfectly designed $3 trillion healthcare delivery system. It's perfectly designed to deliver more and more healthcare. It's not designed to deliver more and more health. But what do people want? Health, not healthcare. And we know how we got here. The incentives are wrong, costs are a black box, which exacerbate volume-driven solutions and a downstream focus. But let me back up a bit. How did we get here? Well, in the early 1900s, life became very complicated. And the example I like to use is the internal combustion engine. There are many parts. I can't explain how they interact, but oil and air go in and mix, and thrust and exhaust are created. Pistons, rotors, turbines all work together in very predictable ways to turn chemical energy into mechanical energy. This is complicated, but a complicated system can be broken down in tidy, deterministic relationships. So the Industrial Revolution was a reflection of life getting complicated, and folks like Henry Ford took a reductionist approach to break down every action into its components and optimize each action using standardized parts. His assembly line took a car that took 3 days to make by a master builder who had years of apprenticeship down to 93 minutes by replaceable and lower cost line workers. His management innovation was a top-down hierarchical approach where managers were paid to think and line workers were paid to do. The big secret here is that standardization was innovation, that variation is the enemy, and that quality is measured by speed. I'll say it again because it's so important. In complicated systems, standardization is innovation. That means the front wheel could be used as a back wheel, or on the left side or the right side. And quality was measured by speed. And compared to most complicated systems, in my current system, Kaiser Permanente, we're pretty good at this stuff. Let me give you an example. How long does it take for an average hip replacement surgery in the hospital? How many days does someone have to stay? Well, depending on the state, I think in New York it was between 3 and 5 days. And that's partly because surgeons want to monitor healing, and it's the safest and easiest way for them to do it in one unit. System was created by and optimized for surgeons, not necessarily by patients. And yet we found that by co-producing the optimal journey for patients requiring a hip replacement, up to half our patients can go home the same day as surgery. How do you achieve a 0-day stay in the hospital? It requires standards that are agreed upon by the entire team caring for the patient. Before surgery, a care coordinator educates the patient and their family about what to expect. Before surgery, a physical therapist visits them in the home to conduct a safety evaluation and reinforce the education. Before surgery, a pharmacist goes over medications the patient will need, if any, how to do sub-Q heparin, things like that. Other care team members come by the patient's home to deliver the properly sized walkers and to make sure that the patient's bed is on the ground floor. Maybe grab bars are installed in the tub. These set expectations for a home recovery, but give the patient the chance to become acquainted with and develop trust in the care team. On the day of the surgery, orthopedic surgeons perform the surgery from an anterior approach, which is a little more difficult for them to learn initially, but it greatly reduces the pain of surgery and recovery speeds up, allowing the patient to walk immediately after the operation. Likewise, orthopedic surgeons select from a small predetermined set of standardized devices. As a result, nurses and other members of the team only have to learn how to handle these few devices. That expertise with fewer devices decreases the rate of complications and decreases infection. After surgery and a meal, the patient shows they can dress and walk 30 to 50 feet, and they go home. And then they get a call from their surgeon saying, "Mrs. Jones, I'm not going to be able to sleep unless you can sleep." And she's feeling pretty good still, so she falls asleep. And the next morning at 9, you can set your watch, a physical therapist arrives at the home, ready to begin the first of 6 in-home PT sessions. At 10 o'clock, a nurse arrives at the home. At noon, a doctor or PA reviews both notes in the electronic health record to make any changes. A PT shows up again at 3 p.m. that day. And this loop continues, and about 2 weeks later, the patient is seen in the ambulatory office. Throughout the process, reliable, excellent care with multiple safety nets is provided in a psychologically safe environment where it's everyone's job to speak up, and team members are collectively responsible for responding to the patient's needs and ensuring the best clinical outcomes. But this thing only works if standards and protocols are strictly followed. If the PT doesn't show up the day after surgery, the system can fail. If the patient doesn't feel safe and know what to expect, they'll go to the emergency room where they may be admitted. Most important, every workflow is created for and with patients in mind. So time for a quick CME quiz. What's the hospital-acquired infection rate for a 0-day hospital stay? Some people need more coffee. It's 0. What are the visiting hours at home? Pretty generous. And how about the quality of the food? Well, we hope it's better than at the hospital. And how much quality time do we give back to patients so they can recover in the comfort of their own homes, surrounded by family, far from the constant din of the hospital? More than 3 days. So when we do 8,000 elective hips and 15,000 elective knees here in Southern California a year, that adds up. And in the metric that matters so much to our patients, their time, it adds up a lot. This sounds appealing, but what about the results? Well, our data show that the readmission rate for our patients who go home immediately after surgery is a little better than those who actually recover in the hospital. And while perhaps the most important thing to achieve these high-quality patient-centered results is standardization, the co-designed templates and protocols, an important part of the work is customization. And the mistake we make too often in medicine is that we start with customization. Every patient is unique. Every patient has nuances that are meaningful. And absolutely this is true. But starting with what's common creates considerable opportunities to raise the bar. Starting with templated workflows for the entire team allows us to raise the standard to the top of the evidence-based hierarchy for our patients, and then on top of standardization, we add customization to the important preferences and expectations of the family and the caregivers and others, and to the local needs of the surgical and clinical care teams. As we customize, we never lose sight of the collective needs of the entire care team, patient, and family. And these collective needs are line of sight to every team member as they iterate to improve the program. With every optimization, also considered are the de-optimizations that might be created for someone else on the team. Let me give you another example since we have a nephrologist in the room. Today, the average American with end-stage renal disease has what I like to call a catastrophic start to hemodialysis. What generally happens is that as kidney function declines, people get sicker and sicker. They may not take their medications to slow progression of renal disease. They're not well educated on the options such as peritoneal dialysis, preemptive kidney transplant, and they may even be in denial about their disease progression. And when the day finally comes, they end up feeling sicker and sicker until they show up in the emergency room and require emergent dialysis with a large catheter stuck in their neck, a few days in the hospital, maybe in the ICU, and then long-term hemodialysis until they get a kidney, which can take years. However, there's something we call an optimal start to dialysis, which happens not enough. In this case, a patient and their family is educated about the progression of kidney disease and may even elect to get a preemptive transplant before needing dialysis. An AV fistula may be placed in advance as an outpatient. A patient may elect to learn about home peritoneal dialysis and select a start date before they feel really sick so that they can get dialysis at home by themselves. And you know we can do this by just tracking serial creatinine, how fast they're progressing, and act on that information in real time. So what is the difference between a catastrophic start and an optimal start? Well, certainly in terms of patient outcomes, given the risks associated with an emergency catheter, an ICU stay, we know the difference. Hemodialysis also means you have to drive to a center, get hooked up to a machine, waste a few hours of your life several times a week staring into space, feeling sick just before each treatment. Well, we know the differences. In fact, in our system, we calculated the first 6 months, an optimal start versus a catastrophic start. The cost difference alone is $48,000. Not to mention quality, safety, all the other things that you get with an optimal start. And so we measure optimal start rate, a patient-centered metric that combines numerous processes and outcomes into one. You can only improve your optimal start rate if your entire health delivery system actually performs as a system. From early diagnosis, quick and appropriate referral to specialists, careful tracking of disease progression, patient education that they actually understand, coordination with surgery teams, transplant teams, scheduling, to make all of this occur as planned. If your system breaks down, that combined metric of an optimal start will quickly deteriorate. So in complicated systems, standardization is innovation and allows for mass customization, which improves the velocity of care, and velocity or speed is a little heralded measure of quality. Now let's shift from the complicated 20th century to the 21st century. The 21st century is not just complicated, it's complex. What is complex? In complex systems, the number of interactions between the components increase exponentially. It's not a gear that turns, then makes another gear turn. It's a single rogue trader in the UK who throws out the whole world's markets. A butterfly in Brazil that causes a tornado in Texas. It's very complex. The key lesson is that solutions to address complicated systems don't work when things are complex. In his book, Team of Teams, General Stanley McChrystal describes how he created the Joint Special Operations Task Force to beat back Al-Qaeda. You know, before 9/11, we had many signals something big was happening, and that it would include using airplanes as bombs and many other details of the perpetrators and their plans. But the FBI, the CIA, and others didn't share. So General McChrystal's solution was to embrace radical transparency. All all the data from every agency available in real time to everyone, not siloed, not need to know. So hand in hand with the radical transparency, you need to flatten the hierarchy and empower the front line. What does this mean? For the Joint Task Force, a low-level drone operator might see a fuzzy signal on the monitor, and given her access to all the other data, push the button to order a full-on airstrike, leveraging millions of dollars of jets and hundreds of troops to obliterate the enemy. General McChrystal created a psychologically safe environment with a shared belief held by members of the team that the group was a safe place to take risks. Without 17 levels of approval needed, they could act with speed and precision, leveraging shared assets to create a level of consciousness and agility across the entire enterprise. And General McChrystal called this shared consciousness and empowered execution. In our complex reality, that shared consciousness and empowered execution is what we need in healthcare. Only then will we be able to get the next order of magnitude of improvement. You know, at Kaiser Permanente, we've embraced these concepts. Today, hypertension control rates in the country are 65%. At Kaiser Permanente, they're 90%. Colorectal cancer survival, 5 years, in the country is at 65%. At Kaiser, it's 80%. And we have plans to halve the death rate over the next 3 years. And I can give you more statistics, but let me give you a real example of how this works. What happens is the receptionist who's checking in Mrs. Hernandez at our Baldwin Park Medical Center gets an alert on his screen saying Mrs. Hernandez is overdue for a colonoscopy. When he sees that, he goes over to her and says, you know, Mrs. Hernandez, I can schedule you for this. I just had mine a few weeks ago. It's really easy. It can help you. It can save your life. Do you mind if I schedule you for this next week? He counsels her. Next week she comes back. A high-grade polyp is found and removed. And so the receptionist, with no clinical training, that same day as the polyp is found, the CEO comes down, visits the receptionist, and in a public ceremony pins the receptionist with a pin that says, I saved a life. That gives purpose and meaning back to the receptionist. It's because the receptionist had actionable data on which he could act. And it flattened the hierarchy, and it improved our rates of colorectal cancer screening and ultimately prevention. That is what's amazing. Oh, and by the way, Henry Ford was wrong. Managers should not only be paid to think and line workers only paid to do. It's a flattened hierarchy nowadays. I told you about the 90% hypertension control rates we have here at Kaiser Permanente. What about the last 10%? And how are we closing that gap? Well, this gets beyond into the complex, and to get there and close that gap, we have to actually redefine what counts as healthcare. So, you know, 1% of our members are responsible for 29% of our costs, which in 2015 meant about $98,000 per person for 40,000 people out of our 4 million in Southern California. And you know who these folks are: multiply comorbid, multiple hypertension, diabetes, behavioral health, substance abuse. So we started cold calling these 1%ers, these super utilizers. We just said, Mrs. Jones, how can we help you? The very first woman we called was an older woman who lived with her 2 dogs in a walk-up apartment with 2 steps in a suburb of Los Angeles. And for the last 6 months, she'd been falling on those 2 steps. She was terrified that she'd have to move, lose her social support, maybe have to give up her dogs, and find a place that she could actually afford. All we did was connect her to a tenants' rights association. And that tenants' rights association, within a month, had a $60 handrail installed on those 2 steps. Now, I'm not saying that we saved her from a hip replacement, but I do know, because we called her back, that we relieved her chronic stress, and we gave her a sense of agency to take care of herself once again. That is redefining the boundaries of what counts as healthcare. It's my job as a health insurance company, as a provider, to not necessarily solve all these problems, but to assess and assist and connect the agencies that already exist that are willing and able to do this work. Today, 1 in 6 people in Los Angeles go to bed hungry. Only 49% are enrolled in food stamps or CalFresh or SNAP benefits. Whose job is it for them to get them a $300 card a month for high quality food? It's my job. Because if I don't, the externalities are in our hospital. When I was commissioner of the state health department in New York, we saw the same thing with housing. We saw that there were 28,724 Medicaid recipients who were costing the state $1 billion a year because either they were homeless and using the ER as a revolving door whenever it got cold in New York, or they were stuck in nursing homes and had no place to go. They didn't need nursing home level care. So we looked at these patients and we saw that at that time, Medicaid in New York paid $755 a day for an inpatient stay, $429 for inpatient psychiatry, $280 a day for a nursing home bed, $129 a day for a day in jail, about $68 for a homeless shelter per day, and $47 a day for supportive housing. We put $388 million into supportive housing to save that $1 billion. Housing is health care. And I'm not suggesting that you as a practicing clinician have to solve each and every one of these problems for your patients. But in our complex reality, starting to think about how do we redefine what counts as health care and addressing the social determinants of health however you can in partnership across the state of Delaware is going to be important. Earlier I spoke with you about Jess, whose calculations showed that less than 0.1% of the time she spent getting care was actually spent treating her condition. Last year she spent 54 days in the hospital, nearly 2 months of her life waiting instead of healing. Maybe health systems should be rated on how much time they give back to patients, how many days at home per year they achieve for people like Jess. You know, a tragic footnote about Jess. She died in August at the age of 29. She has no more time. So I hope you believe, as I do, that speed is quality, that standardization is innovation, and that we need to give patients more of what they want and need from us, meaningful time. In order to get there, we need to embrace radical transparency and completely redefine what counts as healthcare. Thank you.
Thank you, Dr. Shah.